Hello, and thank you for joining me today for the latest in a series of videos designed to complement our other resources. I'm Ed Farnan, and I'm one of the medical legal advisors at the MDU. I was previously a GP partner in practice for 11 years, and I've worked at the MDU since 2013. We're very aware that frontline clinicians have been dealing with unprecedented challenges in recent months, and we're also aware that many of you had to adapt to changes in the way that you work and have had to adopt different methods of consulting with your patients. The advisors at the MDU have been home workers for many years, and our work lends itself to that. Many of you, however, have had to rapidly adapt to consulting remotely by telephone or video, for example, when you previously would have relied on face-to-face consultations using the phone in a more limited way. We have previously provided guidance which can be found on our website and our YouTube channel on some of the medical legal aspects of remote consultations, for instance, on the potential pitfalls of the sharing of images. What we hope to do today is to give you some practical advice about remote consultation, which augments that advice. And while this has been prepared in the context of the acute COVID-19 situation, it's quite possible that there will be long-term changes in day-to-day practice with more use of remote consultation. With that in mind, I'm joined by Dr. Julian Neal and Dr. Bhagat. Julian has been a GP for over 30 years, including more than 20 years as a senior partner in a large group practice on the south coast of England, where he was instrumental in pioneering the introduction of telephone triage for all urgent clinical requests. In addition to a number of other management roles, he is a co-founder and former medical director of Babylon Health, which from the start operated video consultations which were recorded and held permanently on patients' devices. Anshu is an NHS GP and Chief Medical Officer of GPDQ, which he founded in 2015 as a doctor visiting service, enabling patients to see an NHS GP quickly and efficiently. GPDQ also work with the NHS to deliver services directly to NHS patients, alleviating pressure during the COVID-19 pandemic and beyond. And thank you both for joining me today. Julian, if I can start with you and suggest that the first thing to decide if you're considering conducting a remote or virtual consultation, or if you're being asked to do that, is whether you as a doctor feel comfortable doing that rather than a more traditional face-to-face consultation.
Yes, I do. Mind you, I've been in the business for quite a long time. And when we started doing video consultations and telephone triage, that was back in the mid-1990s. It was a very gradual progression. And you've already mentioned in your introduction that a lot of GPs are now being thrust into this sort of work with very little preparation and time to get used to it. I think that's one of the problems. Also, I think from working in an out-of-hours centre for many years, a GP out-of-hours provider, I noticed that there seems to be an innate spread of risk-taking between doctors. Some are innately more comfortable with this sort of form of consulting, and others are rather more reticent. But I think with adequate training and preparation, everybody can be brought up to a reasonable level of skill that makes them more comfortable with the new way of doing things. I think also that there's a very great difference in general terms between advising and consulting remotely with a patient you know, with records that you have and that you've known for many years and that you understand, to consulting with somebody who you've never met remotely ever before. Plus the fact that there's also a huge difference between telehealth and telemedicine. I'm sure we'll come to talk about those differences later on during this discussion.
And I think, Anshu, many doctors, like Julian, will be used to the triaging by telephone, which has been something which we've all done, maybe going back, as he says, as far as the 1990s. Have you any thoughts about how those skills might be transferred into day-to-day video consulting, which might end up replacing some of the more traditional consultations in some circumstances?
Yes, I mean, I think as been mentioned already, we've been doing telephone consultations for as far as I've, certainly the 20 years I've been in medicine. And I think the challenges haven't really changed as we start to move into video. It's just an extension, or I see it as an extension of that existing telephone relationship. Now, I think you're absolutely right. We've really got to be clear that taking a full and thorough history is really one of the key drivers to make sure that we continue as we move into video, and see it as a positive. And I certainly wouldn't want to sort of, reflect too much on the pitfalls, of which there are a few, and we should reflect on those. But I think making sure that we take a full medical history, and the consultation really is slightly different in a sense that how do we approach these type of consultations in terms of our listening abilities? So I think certainly allowing patients to air the reason why they are calling can often open up huge amounts of information for us. The second part of this point, I think, is really about what information do we hold on these patients. Now, whilst we can reflect just briefly now on, as an NHS clinician, I hold all of their medical records. I may have seen them face to face recently. This might be a follow-up or a review or an administrative query. So deciphering sort of what type of consultation we're entering into, I think, is also an important part. I think as we move forward, certainly as telemedicine is starting to become sort of much more veiled across the public and private sector, I think the private sector adds some intriguing challenges, and this is where we don't hold people's medical records, whether that be in the private sector or, quite frankly, even as some secondary care clinicians move into this arena alongside out of hours. I think not holding medical records and not knowing, quite frankly, up to a certain extent, sometimes you don't know anything about this person. And I think this is one of the key drivers, that we do take a full medical history and then move on to understanding what the purpose of this call is. And apart from sort of knowing that you can help somebody, I think one of the key drivers is knowing when you know you can't help somebody.
Yeah, so I think, sort of just to expand on that, there is this learning curve, I think, which we're all going through in terms of consulting patients remotely. And that's becoming more familiar with that as doctors. If you are then happy to proceed with that remote consultation, just picking up what you've said, you have to then make a decision about whether the particular patient that you're going to be assessing can be safely assessed in that way.
Absolutely.
Anshu, do you want to expand on that?
Yeah, I think certainly looking at sort of key criteria, and one of the sort of biggest challenges that I think that I have is making sure that all of the clinicians that work with us always have the concept of red flags in the back of their minds at all times. Knowing, without sounding too pessimistic, but what's the worst thing this could be? And trying to really sort of reflect backwards from this, in that, and yes, if we're not talking administrative queries, but if somebody, for example, presents with an abdominal pain, well, I think, there are already limitations where we're already going to be faced with. So I think expecting the worst, thinking of arguably the red flags and all of the emergency scenarios, I think is often a key triage tool.
Yeah, so again, maybe Julian can expand on that to some extent. Even if it seems appropriate at the outset, and if that was the intention initially to conduct a consultation remotely, there will be times when your view of that changes, and I suppose you always have to have your antennae up for changing dynamics. Do you agree?
Yes, I do. This relates also to doctors in secondary care who may be starting to use this sort of way of consulting. Again, it depends very much on what the consultation is all about. If it's about reviewing someone with a known diagnosis, for example, someone with diabetes, a diabetologist in hospital may be interested particularly in numbers. What's the hemoglobin H1C been like, blood pressures, and that, so on and so forth. So it's very different consulting with a known patient with a known problem. Where it becomes more difficult and challenging, but I agree, it can be done very safely, is when the consultation is with a patient that you don't know particularly, you don't have any medical information about, and you don't know why they're calling. My firm belief is that the history is absolutely paramount, has just been discussed, and you can't rush it. It really goes back to first principles, is that about 80% of a diagnosis is based upon a history, 15% on examination, and the rest on investigation. And I think when one is consulting with somebody either with a video link or by telephone, it is really important to concentrate on the history. And I suspect we're going to be emphasizing that time and time again. Also, apart from just having red flags in your mind, I think you have to start with an open mind and keep it open. You really do have to ask an open question, let the patient describe in an unhurried way what they believe their problem is, what symptoms they have, what concerns they have, and try not to interrupt them. This may sound like a very tedious way of conducting a consultation, but in the absence of some of the soft signs that one has when you're face to face, it's really important that you concentrate on the history.
And I suppose one of the things you're trying to avoid by doing that is the sort of the concept of confirmation bias, of being led down sort of a blind alley to some extent.
Yeah, absolutely. One of the problems with diagnosis in general terms is, in fact, going down what I call diagnostic cul-de-sacs, um,
Yeah.
stopping the open mind and jumping to conclusions. In my experience, this is very easily done, especially when one is in a hurry. Maybe one takes the patient's history on face value and immediately closes off a whole variety of possibilities. This has to be avoided at all costs during a video consultation. Also, I think at the very beginning, it's rather important to build up a rapport with the patient. We are talking very much about this being a relatively new technique, video consultations for GPs and doctors in secondary care. But remember, it's also a new way of consulting for the patient. They may feel slightly anxious about the whole procedure as well. So it is important that you put the patient at ease, because if they're at ease and not anxious, they're more likely to be able to tell you what's wrong with them.
Yeah, I think one of the things that we've said in some of our other resources is the importance of having a short period at the start of a consultation where you maybe have a slightly different hat on, where you're more of the administrator, where you can get some of those sort of administrative things, but also putting the patient at their ease, getting that bit done fairly early on before you then switch to be a clinician. We've talked about maybe the importance of history and how vital that is, and taking a good and consistent history. Anshu, perhaps, are you able to expand perhaps on some of the more problematic sides of this, maybe some of the limitations of video as a means of assessing some problems? We touched on it to some extent earlier.
I think one of the key bits is really around just to reflect quickly on something Julian said there, which was around um, how do you get all of this information out, and how do we not lead people down a road that we want to go down? And I think going through that consultation style has never been so important than it is now in video, and understanding patients' ideas, concerns, and really kind of what are they expecting from this call. I think often complaints arise from that I wasn't listened to, and I think this is a really important part of consultation styles, even more so where you don't necessarily have the benefit of having somebody in the room, where you have other soft cues that you can rely on. So I think certainly getting the fuller history. I think where some of the challenges arise are certainly examination. And I think, whilst there are many things we can examine, there are probably arguably more that we can't. And I think it's really, sort of harking back to that sort of that taking that history thoroughly, I think is really important. I think visual cues are important, and I think certainly give us the advancement over telephone, where we can actually see people. So you can observe simple things like respiratory rates and things like this. But again, where we probably get sort of halted in our tracks is where we do need to examine somebody's abdomen, or listen to somebody's heart, where we can't do those sort of examinations, where face-to-face is never going to be replaced. I think some of the other challenges are around sort of what I call environmental concerns. And whilst we do get some view on video of how people are, where they're living, some of the safeguarding issues, I think certainly, whilst we've reflected on red alarm bells and red flags, safeguarding is certainly one of them that should sit at the top of this as well, especially when we're consulting with children. Often we do get calls where it's about, you're speaking to the mother. Well, where's the baby? Well, the baby's asleep. So often, these are some of the reflective things that we are now talking about, is how do we reassure ourselves that that if we're talking about the child and they're asleep, often what we often ask our parents to do is, could you please show me your child? And it's a bit of an odd thing to say, but it certainly is one of these things that we do want to make sure that we have that wider view.
Yeah, and I think I agree. And one of the things that the GMC says in its core guidance, good medical practice, is that where necessary, you must examine the patient. And that doesn't necessarily mean you must terminate the remote consultation. It is, as you said, possible to do some of those examinations in a remote setting. And in addition, all doctors, I think, are very good at having a low threshold for considering safeguarding issues and are quite good at that and picking things up sometimes with the softest of markers. And in those situations, again, your threshold for seeing somebody face to face rather than remotely might be slightly lower. I don't know, Julian, if you have anything to add to that.
Well, yes. I mean, I can speak from experience of working in the private sector here when one was taking a history and examining people through a video consultation. Increasingly nowadays, there are peripheral devices that can measure blood pressure, pulse, temperature, oxygen saturation, and so on and so forth. And certainly in the private sector, many patients who are using these facilities can provide basic vital signs. Now, often in my medical career, taking a blood pressure has got me out of a difficulty. I remember one instance when I was asked to see somebody in the flesh who was apparently hyperventilating, a young chap. Cut a long story short, he looked as though he was hyperventilating, having a panic attack. But in fact, what he was having was in fact pneumococcal septicemia, and was having Kussmaul breathing, respiration. And were it not for the fact I took the blood pressure and couldn't find a systolic higher than 80, I might have left the patient. Now, in a video consultation, having some vital signs does increase the ability of one to come to a safe judgment. As far as the limitations is concerned, I'd like to come back to that. And in my experience, there are certain limitations which one should be aware of. First of all, the cognition of the patient. As I said earlier, sometimes this might be a difficult thing for a patient to do, to conduct a consultation by video link. If you're worried about their ability to understand or your ability to understand them, that's an alarm bell. One should really fall back upon a face-to-face. Likewise, the emotional condition of a patient. Pain. Pain is a difficult thing. We don't have painometers. And trying to describe pain remotely is quite difficult, especially if it's abdominal pain, pelvic pain, chest pain, headache, which is head pain. All these things should alert one to the possibility of really taking a history, but following it up with a face-to-face. I've come across many a case recently where the wrong conclusions have been drawn about abdominal pain, because there are times you need to put hands on tummy and feel what's going on. And she mentioned children. This is also difficult at both ends of the life spectrum, babies, infants, children, and the elderly. My own view is that one should be more cautious with this age group because they present differently, not according to textbooks. Likewise, there are some other things I think one should, during a consultation, just have a few alarm bells going. New urinary incontinence, delirium, short of breath, and so on and so forth. Symptoms that suggest that there might be something more serious going on. And really, in that situation, it's all about carrying risk. Am I in a position on this history to exclude certain serious things? And if I'm not, then thank the patient for giving you all the details, but then arrange a face-to-face consultation. That will get you out of trouble more times than I can think of.
Yeah. I think we would all agree with that. If we go back to the sort of the concept of examining patients in that remote setting, and perhaps with my medical legal hat on, I think one of the things I would emphasize is the importance of obtaining explicit consent for an examination by video link, and also consider where it's practical and possible the use of chaperones. It's also important, I think, to think about whether an examination which a patient might regard as being intimate is appropriate in a remote consultation. And we do touch on that in some of our other guidance. In practical terms, it can be more difficult in a remote setting to establish a rapport with a patient. And do you have any thoughts about that? Again, we have touched on it slightly earlier. Anshu, perhaps if you've got anything to offer there.
Yeah, I mean, I think suppose it's the type of patient that you're seeing. I mean, if I can reflect on that, if I've looked after somebody for a fair while and I've seen them and I know them, and I think that rapport already exists. But I think what we're seeing more and more is that where we are seeing patients we've never seen before, and arguably in that scenario where we don't hold their medical record. So I think consultation styles are hugely important, and making sure that we do come across approachable, that we do come across in a professional way, and don't rush patients. I think patients will always feel, even if it's, and we're not talking sort of highly sensitive areas, but even if it's a mole on the sort of inner thigh, for example, I think patients would probably find that okay to show you that mole, but only if there was an adequate sort of, if the patient had enough time to express why they were there, they had enough time to express their ideas, concerns, and expectations, where they do feel comfortable now in this setting. So it is up to us to definitely make sure that we come across in the right way, that we come across in a professional manner. But going back to our basic communication skills, and allowing patients, like we've already said, which is a new way of consulting, for them to feel comfortable with it, as well as we are starting to.
May I just add to that?
Of course.
I mean, I agree with everything that's just been said. One of the things that I found particularly helpful doing a video consultation is, again, it's to go back on first principles and taking history. And that is every now and again just to say, would you mind, Orphy, if I just sort of summarize what you've just said? So in other words, you're checking from time to time with the patient that you actually understand what they've said. One of the areas of difficulty that I've encountered in my professional career, both face-to-face and otherwise, is in fact, it's all about communication. If the communication's poor, two things happen. You're more likely to get a complaint, and you're more likely to get the diagnosis wrong. So we're back to communication again. So unhurried. The other thing is being professional in a video consultation. It doesn't do for your wife to come in or a child to interrupt the consultation. In previous existences, I've trained GPs to set up what I would call pop-up clinics. So an area of their house where they can set up their video link. It looks professional, and the patient therefore feels as though this is a professional talking to them, but who will then put them at their ease. So it's very important that we combine informality with professionalism, so we can actually get the patient to feel comfortable and to give the best history that is possible from them without being threatened. But again, I come back to, you cannot rush this. It's got to take time.
And maybe if I could just add something on that, agreed, Julian, is also, I think sometimes when we, we don't want to come across as if, well, it's this video consultation and I'm going to fix everything on this, and there probably won't be much else I can do beyond this. I think reassuring patients that this is just a modality that we are using to, quite frankly, take a good history. Now, ultimately, not all consultations are going to be able to be resolved like this. And one of the key things I've found in recent times is that, access, if we go back to pre-COVID, arguably, where, the majority of our consultations were face-to-face, patients were waiting 2 weeks, 3 weeks for an appointment. Now, they may not be seeking out any other advice or healthcare within that time of waiting for the appointment. And actually, what I've found, and I can probably pick at least 5 every week, where they've got the appointment within 24 hours, and I've managed to take a full history and examination. And I've said, well, we can't really wait 2 weeks for this. I'm going to bring you in tomorrow morning. So quite frankly, I'm glad we had this modality. Not that I could have concluded it safely, but it was a good way for me to gather information, triage, and bring them in for that examination. So outcomes can improve.
Yes, I would agree with that entirely. It enables one to get a sort of head start. And if you're going to say, as a follow-on from the video remote consultation, that I need to see you, it gives you thinking time as well. So when they come in the next day, or when you arrange a face-to-face consultation, you're halfway there. and they're not seeing you de novo. You've already built up a rapport, so you can then quite efficiently hone in on the vital parts of the problem.
So if I can maybe sort of tie that together to some extent, I think what we're picking up is that you can do a huge amount in a remote setting that you would also be able to do face to face. What's important perhaps is A, to recognize the limitations of the medium, but also perhaps because of those limitations, you might need to do things in a slightly more structured way. Whereas in this consultation, things can move about slightly more fluidly, just to make sure that you have addressed everything that you need to address. Would that be a fair way of summing that up?
Yes, I think that's absolutely right. And somewhere along the line, during a consultation with someone you don't know, with a problem that needs to be triaged for the first time, it's going back to basic training. If you can't touch or see or examine the patient face to face, I actually think one of the important things one should do, and you can do this with experience, it doesn't have to be a particularly threatening or rigid exercise. You can go through a fairly thorough review of systems. So you can ask a few questions about respiratory system, urinary system, etc. All the while, you're starting with a broad brush, an open possibility of a diagnosis, and you're gradually narrowing it down to a differential diagnosis. And the more experience you are at taking history and talking to a patient with a video link, the easier this becomes. So even a doctor that starts off slightly reticent, this is a new way, they will, with experience, become more comfortable with it. They may be slower, that doesn't matter, but they'll be safe.
Yeah, agreed. I mean, one of the things that I find, certainly over the last 6 months, one of the things that we've been trying to do is how do we minimize variance between clinicians with the same presenting complaint? And this has been always a challenge. We're all different clinicians. We all have our own ways of doing things, and that's fine. I think. However, as we start to enter this, using this modality more and more, what we want to do is be able to retrospectively reflect and go, well, could this consultation have been handled differently? Why, compared to this consultation? So, one of the things that we've started to do now is look at arguably not. I don't want to call it necessarily template medicine, but it's there to help you understand that there's a few questions that you may want to ask with a particular symptom. I think what you've just mentioned, Julian, about multi-system checks, gosh, this has got me out of trouble many a time, quite frankly, where, we're talking about an ear problem and before you know it, gosh, suddenly we're talking about swallowing difficulties. And so I think it's really important as part of a documentation piece. And I think certainly medico-legally, something that, I've always talked about is, well, if you haven't documented it, let's assume you haven't done it. And I think it's a really important part of learning for all clinicians, especially in an ecosystem of digital medicine, is how do we make a headache consultation remotely standardized? How do we standardize certain presentations? Just so that it allows us to, I don't want to say think less, but certainly allows us to have those triggers so that we ask them.
Yes, there's almost an analogy here with the aviation industry. No matter how skilled and experienced the pilots, they have to go through a checklist before they take off, and a checklist before they land, flaps, ailerons, etc. So it becomes ingrained with the habit of taking history. Now, you've just mentioned also recording. We haven't discussed that yet. I actually think having a video consultation or a telephone consultation is actually more important, that you record things more obsessively. It also provides you with a checklist. And if there are any problems later on, or when you're seeing the patient the next day or the day after, you've got a very thorough history documented. And that leads me to the difficulty of how do you do it? I remember I'm old enough to remember when computers first came into general practice. And some of my partners they avoided looking at they were looking at the screen the whole time. Now, obviously, in a video consultation, you're trying to look at the patient by looking at your camera. There may be times when you have to say, would you mind awfully if I just record this now? I'm going to look away for a few seconds. Don't worry, I'm not ignoring you, I'm writing it down. At the end of the consultation, while it's fresh in your memory, write the salient positive findings down. It helps you and it'll get you out of trouble in the future.
if I go back to my GP training days, and I think a version of it still does exist. We had to record ourselves consulting in the room. We set up a camera in the corner, and it's interesting when I reflect back, and I've digitized them now, just to sort of look back, and albeit it was a face-to-face consultation, we'd pretty much record everything up to the examination, really. And the questioning and the style of the questioning and the socio sort of questioning that we were asking, I think it's really important skills that we can bring forward to this. And when you listen and watch yourself talking to a patient, it can be quite enlightening, actually, in terms of how many sort of cues you can get, not just from face to face, but from a video consultation as well.
Again, if I can just add to that, that is absolutely right. One of the things I learned later on in my career is that some patients didn't think I listened, but I listened very carefully. But I had a terrible habit of gazing up at the ceiling when patients were talking to me. And therefore they think I was thinking about my next holiday. I wasn't. I was thinking very carefully. And it wasn't until a multi-system feedback came back that the patient said, "We like Dr. Neal, but he doesn't appear to listen." I changed my practice overnight. So in terms of video consultations, no matter how experienced you are, it is extremely, I would agree entirely, we need to audit our performance. I hate the word audit, but you know what I mean. We need to see how we're performing, because there may be things there that you didn't know you did. And if you change one or two things, it'll help tremendously in the future.
It'd be great to see that in our training requirements, actually. I think, video remote consulting is not going anywhere. It's only going to increase across the over the coming years, and I think it'd be lovely to see this embedded into medical school training, and certainly into the GP VTS training, so that people are prepared, not just for face to face, but certainly to how to practice safely.
I agree entirely.
You sort of picked up two things there. One was the importance of good record keeping, and that's important both from a clinical perspective, but also from a medical legal perspective. And the other thing is that, good communication and not only listening, but being seen to listen can prevent an awful lot of complaints. I think a break is never what is intended by a doctor, but when it does happen inadvertently, it's what often will lead to a complaint. Can I maybe just to tie things up at the end, do you have any particular thoughts or advice in terms of ending the consultation, perhaps? Anshu first, maybe?
Yeah, I mean, I think something that Julian picked up on earlier was summarizing what you've just heard. And I think it's a really important tool that I find very useful as well, where it sounds quite repetitive, but you end up replaying what you've heard and that we're all on the same page. I think creating a plan with the patient, I think having them on board with that plan is a really important part of compliance to this consultation, I feel. But I think safety netting and understanding the limitations of the consultations. And I would always say err on the side of caution here. If there is a slight bit in your mind where you say, gosh, I could really do with just popping my hand on somebody's tummy or something like that, and then do it. I think taking calculated risk is something we've been experts at in primary care over the years, and we take that risk through face-to-face medicine, where we have examined people and we can give people limited reassurance, albeit. But certainly, as remote medicine kicks in, is not to tell the patient, well, this is it, goodbye. I think giving them options of how, number one, they can come back and access. Number two, if you want to bring them back, make their lives easier. I will not tell a patient to go back into reception, to go and book an appointment to come and see me. I go into the clinic slots and I book them myself, so that they leave with a firm date and a time of where to come. I think educating patients on what to do if things get worse. And this is the sort of safety netting element that should be part of every consultation, and documented, that these are the pitfalls of, well, if this is a hernia, well, look, these are the worrying things about a hernia you need to be aware of, or head injury, or whatever these sort of safety net alerts are making sure that the patient is explained that in a clear and understandable manner.
Yes, I would agree with all of that. And regarding the safety netting, just as I said earlier, it's helpful to take stock during a consultation to explain to the patient, you're just checking that your understanding is correct. With safety netting, it's the other way around. You should ask the patient, do you understand, well, you have to put it like this, but do you feel happy about the way we've left it? Do you understand what to do? In other words, the advice I've given you, can you maybe just talk me through what I've asked you to do? Because patients sometimes get a completely wrong idea of what you've been trying to explain. So safety netting, absolutely vital, but do try and reassure oneself that the patient understands the signposts and the safety netting you've provided for them. Also, it's the by the way, doc. This is often the reason that patients come to see you in a face-to-face. They get up, 10 minutes or whatever is up, and as they're going to the door, they turn around and say, by the way, doc. Again, I think we need, during a video consultation, to be able to say to the patient when it's almost come to the end, is there anything else you'd like to say? Do you have any more worries? And leave it then and wait for the silence. Don't hurry them. If there isn't anything, thank them and all the rest of it, and then you conclude the consultation. I used to conclude all consultations with a handshake. Now, obviously, in socially distanced times, you can't do that. But some way of actually bonding at the end of a consultation to make them feel comfortable that you are an accommodating doctor, they can ring you back, you have made an appointment, you are looking forward to seeing them at a time that you've actually arranged yourself. It's all really important so that they go away thinking, that doctor cared. He may not have seen me in the consulting room, but I knew he understood my problem and he cared. And that's really where we want to leave things, I think, in any consultation, but particularly through a video one.
That's really helpful. Julian and Anshu, I'm very grateful to you both for your insights. I certainly have found them extremely helpful, and hopefully our members will too. As we continue through this very unusual time, we're keeping this video series going, and we're happy to address any other medical legal questions, whether those be coronavirus related or otherwise. If you have a question that you think would be good for us to deal with in future videos, then please email us at feedback@themdu.com. And if you do want a personal response or have a specific question for the advisory team, then please write to us in the usual way at advisory@themdu.com. That's all for now. Thank you very much for your time.
Thank you.
Okay, thank you.